All right, shall we begin? So, introduction to the U.S. healthcare system. So I'm Paul Brown. I'm a professor here at UC Merced. So I've been here since 2011. I was the first hire in public health back in 2011. I've been a number of different type of places. I'm an economist by training. So I went to UCSB as an undergraduate and was a joint psychology and economics major. Then went off to graduate school in economics at Wisconsin. And got a PhD in economics. And I taught at UMass Boston for about 5 years, 6 years. So for a while at UMass Boston. And then anyone from Boston? No. Anyone been to Boston? Oh, you should go to Boston. Boston's a great city. Down in taught at UMass Boston. Then moved down to New Zealand. Lived in New Zealand for 13 years, 14 years. Came back to North Carolina, got a job at UNC, so worked at UNC for a bit, and then came here. And I've been here since then. And I go into this because I just want you to know that, as an economist, so I was trained as an economist, then what happens is that when I moved down to New Zealand, my wife had a job down there. I didn't have a job. I thought I was just going to hang out. And after about a month of me hanging out, she said, you should really go get a job. And so I went and looked in the paper, and there was no jobs for basically just for the type of thing I was doing as an economist, but there was a job for a health economist in the government, in the Ministry of Health. And New Zealand they have a universal healthcare system, so that in New Zealand, hospitals are free, and if you go to the GP, go to the family doctor, you pay $30 or something like that. So all prescriptions are $15. So if you get a prescription, it's $15. So it's a universal healthcare system, and that it's run by it's very there's a minister of health, and there's a ministry of health, and then the ministry runs the hospital and runs all these other things. So I was working. They were looking for a health economist. I told them that I had never done anything in health before, and I interviewed, got the job. In fact, they called me up and they said that I was the top person in the job for their interview. And then they told me I was the only person in the interview, who applied for it. In fact, I was the only person who applied for it for 2 years, and they decided just to give it to me because they thought, well, no one else has applied. So I worked for the ministry for a year. In fact, the day I started in the Ministry of Health, they announced that they were going through a big restructuring. And so after a year, they laid us all off. And at that point, I had a job over in the University of Auckland in the medical school. So I then moved over to the medical school. And so I worked in the medical school for 10, 11 years, something like that. And that's where I really sort of became a health economist, was doing that. And then, so I go through all this because, what a health economist does is that we kind of do things like look at the healthcare system. So we're going to talk a lot about the Affordable Care Act in here, especially in the early parts of the class. And so all the stuff that in terms of designing the Affordable Care Act and what it was going to look like, all that kind of comes from health economics. So there was mostly health economists who were working on that. And that health economists, then we tend to deal with things like how it's structured and how efficient the system is, and how it's organized. The good news for this class is that the US is a very inefficient and very poorly organized system, so there's lots to talk about. But it means that I'll be sort of approaching this class in terms of, from the standpoint of like looking at it like at the efficiency of the system in terms of the big picture overview. Right now, what I do is I do a lot with public health departments. So I've got a couple of big projects that with the California Department of Public Health, where they're basically looking at how to go through and improve decision-making in both local and state public health departments. So it means that as sort of a research thing, I'm spending a lot of time going through and looking at what public health departments do. So we'll also in this class, I'll tell you a lot about what I've learned in terms of what public health departments do and what they could do and things. And I think it's relevant for you because, one, it's part of the class, so I'll test you on it. But then also because, I think when you get out of here and get a job as a public health major, is that a lot of people go to work for public health departments. So it's really helpful to kind of understand kind of what public health departments do, what their role is, where they fit into everything, into the healthcare system. So that's what we're going to talk a lot about, especially towards the end of the class. It's just kind of, what does public health do as an agency within the within both the county and the state and at the federal level. No TAs for this class, so it's just me. So I think I think there's probably about 70 people in the class. So 70 people, just me. It means I'll probably have to be fairly organized in terms of how it is that we meet together. So we'll meet in class, but then I'll have an office hour. But then also I'll have special office hours before the like the assignments are due. So that in those office hours I'll go over more kind of like the nuts and bolts about if you have questions about the assignments. So it just means that we're going to have to kind of get through this together without a TA, because it means that you got me and only me along the way. So what I'll do is I'll just give you an overview of the course today. And talk about how I'm going to do grading. And for those who are in the morning class, I apologize. I'm going to go through it again. And then I'll just start on the introduction to the healthcare system. The healthcare system, the introduction to the healthcare system is probably going to last all through next week as well, because it's pretty complicated. At the same time, I think it's good to do it at the start so that you kind of know the language of what we're talking about when we start getting into why the system looks like it does. So we'll meet here on Tuesday and Thursdays at 3 to 4:15. I'm recording the lecture, so on Zoom. And what I'll do then is I'll take the lecture and I'll put it up onto a YouTube channel so that if you want to go back and look at later on, you can. Also, if it means that if you miss a class and you can't come and you just want to watch the YouTube channel, then you can watch it there, because it's going to be the same thing. The thing you'll miss is, like I won't spend the time kind of on Zoom switching back and forth between all the different documents that I show. So it's not going to be a complete record of everything we do, but it'll be pretty close. And then the other thing is that, until the microphones get set up, there won't be any, you won't be able to hear any comments from people. So it just means that treat the YouTube Zoom lectures as something to remind you of what we did, but it's not going to be exactly what we're doing in class. Any questions about that? Okay. In terms of the way that we'll do it in the lectures is that after these first, next week we'll do sort of just both an introduction. And then I'm going to go through the history of the US healthcare system. And the reason I'm going to go through the history is because it turns out that you really can't understand why it is that we have such a screwed up system until you understand kind of historically how we got such a screwed up system and why other countries don't have as complicated a system as we have. So I'm going to go through it, and that will probably last a number of different weeks, probably till the end of September. But the other thing so I'll do that on Tuesdays. And then on Thursdays, what I'll do is we'll cover topics. So there's certain kind of key topics that you're going to need to know to understand the healthcare system, like adverse selection, right? Adverse selection sounds like something which is, kind of would not be relevant to anything that you'd ever care about. But it turns out it's the key thing that explains a lot about the Affordable Care Act and why the Affordable Care Act was organized the way it is, was all because of adverse selection. So I'll go through those type of concepts as well as the class goes in. And then that will probably last until probably the midterm. And then after the midterm, then we'll do more different type of topics from then on. The class ends, and the final week of class will be a review session and a midterm. So essentially we have 13 weeks together. There'll be 2 midterms. One of them is the first one will be, we'll cover the material up to that. The second will cover the last part of the material. They'll be non-cumulative in the sense that the second midterm, I'm not going to test you per se upon things that are in the first midterm. However, namely that we did in the first part of the course. But there are, there are some limitations to that. So like, there are some key concepts that we're going to use throughout the class. And so, I will go through and ask you about things that require knowledge about what happened in the first part of the class. Just I'm not going to ask you like the details about the history of that US healthcare system won't be on the second exam. So for the most part, the material on the first part of the exam will just cover the first part of the course. Material on the second will just cover the second part of the course. Both exams are in person, so they'll be here in person. If you can't make the exam, or if you need to have special type of arrangements, like more time, whatever it's going to be, contact disability services early. Yeah, so what I've done in the past is that for the exam is that I'll make up a list of terms, and I'll go through and I'll do a review session before. So the terms will kind of cover the key concepts. And then I'll go through and I'll give you I'll do a review session before. But then the other thing I do is I let you bring in a sheet of paper, and on the sheet of paper, you can write whatever you want on the front and back, so that you don't have to memorize anything. But at the same time, it does kind of, help you sort of organize stuff as well. So that there will be kind of, we'll nail it. And you'll see is that there's no book in the class. So we've got, most of what we're going to do is off of slides. So, and what I'll do on the slides is I'll give you a lot of information on these slides as we go through, because it's basically the book. So I think the way to treat the slides as if that's the book, and then I'll give you terms in there that you can go through that, that kind of concentrate on those terms, because that's the key thing to ask you about. Other questions about the exam or the format or anything? You have a question? No, I mean, do I take attendance? No, I don't. But if you're concerned about it, then what we could do is you could take attendance for us. So everyone agree she'll take attendance and we'll make it mandatory? Because no, it's your choice. And at the same time, so one thing that if you're the type of person who likes to do things like come to class and watch movies, let's say, right? Then I'd say, don't come to class. You can just, watch it on YouTube later on. But it gets sort of annoying for people if you're kind of doing something along the way that's not really, involved with the class. So because everything will be on YouTube, I'd say if you're the type of person who doesn't really want to pay attention in class, then just watch it on YouTube and don't come to class. I'm not going to take attendance. That said, once COVID started, is that I taught this totally online. And then when COVID, ended, did it end? Last year, when they wanted us all to be back in person, is that I sort of made it available on Zoom, so people could either just watch it on YouTube, they could watch it on Zoom when I talked, and they could come to class. And so I went through then, and at the midterms, I went through and I asked people what they primarily did, and then I compared the grades between people who just did YouTube, who did only on Zoom, and who did in class. And there was about a 5-point difference in the exams for each of those different type of modes. So people who did YouTube, definitely was like a grade lower than people who did it on Zoom, and they were about half grade lower than people who came to class. So part of me thinks, well, maybe it's just because students who are the most motivated come to class, right? Which is partly true. But I think it's also that, and if you're the type of person who, when there's a Zoom lecture going on, you find yourself doing things like doing dishes or, watching the movie on your phone or whatever it's going to be, that means you're not really paying attention. And at the end of it, regardless of what mode of giving you information that we try, is that if you don't engage with it, you're not going to learn it. And so, and the way to engage with it is to pay attention to it and to take notes off of it and all the rest of it. And the more that you engage, the better you do. The less you engage, the worse you do. So that's why, no, I don't take attendance. But at the same time, if you want to do well in the class, come to class. Other questions? Yeah.
Is there any group projects?
No, there's no group projects, but there are projects that like I'm going to ask you to figure out, like one of them is dealing with insurance, figuring out premiums for insurance, which is, you might think to yourself, that's probably the most boring thing in the world. I've asked students at the end of class what thing that they got the most out of, and they always say the insurance stuff, doing the insurance stuff. Because, you all have to buy insurance. And so it all kind of makes clear how insurance works. And so for those things, I'd say, and for everything that you do, feel free to work together and to collaborate and do whatever you want, because I think you learn better if you kind of work together along the way. And that, if you're the type of person who doesn't want to work and you just want to sponge off someone who's a straight A student, I think what you'll find is that they're probably not going to be your friends for very long. So I think that, there's a nice mechanism for making sure that people aren't social loafers when it comes to this. So work together. Other questions? Okay. All right. So I gave you the syllabus. So, I won't go through it, but you can go through the syllabus. The main thing is that lectures are the most important. The lecture notes are the most important. When I go through things, I'm going to fly through it, a lot of it, because I'm going to just sort of assume that you're going to go back and read it more carefully when we're done. And I'll put them on YouTube so you can, they'll be there to remember. But I really would treat the lecture notes as the main book of the class. I'm going to give you some readings along the way. And what I'll do is I'll highlight in the readings kind of what's the important things. Sometimes I give you a reading where I'm just giving it to you for your background. So, and I think what you can do is sort of skim through it. So for example, on the US healthcare system, I've given you there's an organization called the European Observatory, which is in the Europe. And what they do is they put out country profiles of healthcare systems around the world. So, if you ever want to know what's the healthcare system like in Mexico, is that you can go on there and there'll be a big report, and it just, describes in pretty simple languages what the healthcare system is like. So I gave you the one for the US. I think it's 110 pages, right? So I'm not expecting you to carefully read 110 pages about the US healthcare system. But what I would say is to go through and skim through it. And that, because as I'm going through and I'm talking about things about how the US healthcare system is organized, you'll see it's pretty complicated. And so I think if you go there, you can find that they kind of follow along too in terms of saying, the things I'm saying. So I'd say use that type of thing, use as a reference. There'll be other types of things I give you, which will be very short, like how George Washington died, tragic tale. And for that one, you can read it all. It's not that long. And then there'll be things in the middle. So I'm going to give you some readings that really are kind of important to read, and those I'll highlight what's important to read out of it, but still at the same time, they're like New Yorker articles, so they're pretty long, but at the same time, well written and interesting. Let's see, anything else about readings or course? Yeah. Yeah, so if you go on CAP courses, you'll see is that what I do is I'll create a module for each like section. So there's a module that's on there now that says August 24th that has this lecture. So it has these lecture notes and it's got that reading in there. And then what I'll do is I'll upload the readings and the lecture notes into a module. Sometimes if I don't finish everything today and that's in the lecture notes, I'll just continue on Tuesday. So at some point I might go through and consolidate and put it all together into one big kind of lecture, one big PowerPoint, so you have it all together, but there's no overlap between the two. But for the most part, they'll always be there. Other questions? So as I mentioned, two midterms. First one's worth 100 points, second one worth 150. Make it worth 150, partly just because it gives you a chance that if you bomb, a lot of people have never taken a test from me. So if you don't do well in the first test, it gives you a chance to kind of make up and do better in the second test. If you do really well on the second test and very poorly on the first test, I'll take them into consideration for the grade. And then there's 5 assignments. Each assignment's worth 10 points. Can you turn in late assignments? I accept late assignments, but what I do is I start to mark down the number of points that you get. But I'd rather that if you're going to, if for some reason you're going to be late in assignment, I'd rather you do it and learn than not to do it. At the same time, I don't want to penalize people to turn it on time. So the first assignment's due next week. And it's on CAP courses, so it should be released to you right now. What I'm asking you to do is basically just list the question that you have about the U.S. healthcare system. And that, this can be, and then give me some brief explanation for why it is that you have that question. And it can be something that is just a general question, like, why is the healthcare system so expensive? Something like that, right? Or it can be something that's much more personal. And that, like, if you've had an experience, or if a family member's had an experience, and you didn't know why it was that, this happened within the healthcare, you can tell me about it. And if you want to go ahead and tell me some background of it, don't tell me anything that you don't want me to know. I'll keep everything confidential, so it's just me who's going to see it. But at the same time, if there's anything you don't want me to know, don't tell me. But if you want to give me some background in terms of, what happens, what led to this question, then go and write it in. I've done this for a number of years, and it's a good way of for all of us to kind of get a reality check in terms of the problems that people have with healthcare. My experience has taught me is that the people who like their healthcare the best are the ones who never use it, and the people who use their healthcare the most, especially if I have a chronic condition, that's when your satisfaction tends to go down a lot, and that some really bad things happen to people in healthcare. So if you want to go through and ask me a question about that, then what I'll do is that at the end of the semester, I'll look at those questions and try to make sure we're going to cover as we go through. But at the end of the semester, if there's unanswered questions, what I'll do is I'll just devote a lecture, and we'll just go through and just answer all the unanswered questions along the way. Okay, so questions about assignment 1? All right, I'll create a way for you to turn it in. I have to figure out how to do that since there's no TA. But anyways, the assignment's up there. Okay, grading. I'm going to go into some detail about how I grade, because I've come to realize is that the way that I grade is different than how other people grade. So 2 midterms, 100 points, 150 points, 5 assignments, each worth 10 points. That makes 300 points total. So let's say there are these 5 students who get, and this is the scores that they get. So, there's Paul, Ringo, John, George, and Billy, the 5th Beatle. So let's say Paul gets 80 on the first, 80 out of 100 on the first one, 120 out of 150 on the second one. Billy gets 65 and 75. Paul turns in all the assignments. Billy turns in 1 assignment. And so then this is what their point total is. So the first thing to note is that I don't keep track of letter grades. I'll give you a letter grade after the midterm just to let you know basically where you are. But for the most part, but I really just sort of do it by points. And then what I do is at the end of the semester, I just add all the points up. So let's say it looked like this, these 5. Well, if you look at the university's grading scale, the university's grading scale is essentially, out of 100 points, it looks like this. So this is what the university suggests that we use. So if you translate that at the 300, that means that to get an A+, you'd have to get between 291 and 300. And to get an A, you'd have to go between 282 and 290. So my 5 students would have all done relatively poorly, as the top score would have been a B-, and 2 people would have failed them. So it means that, if we have a large class like this, is that you're looking at a distribution like that, just using the university grading scale. So the question is, well, why? Why are the scores so low, right? So it could be low is because none of you study. You all just watch movies all day. And so, but I found that that's never true. I've discovered, after lots of different classes, I've never had a class where I thought, people just aren't trying in this class. So I discount that one. I think that, people generally try, and they, try to do it, and they want to learn. So that one's out. I didn't do a good job. Is that a possibility? Yes, that's a possibility, right? I could just be a lousy lecturer, of which case then, you haven't learned the material because I haven't taught it to you very well. So that's a possibility. Test was hard. That's my test. I usually, the average of my test is about 60 out of 100. So that's pretty low. And so I thought about what to do about this, right? Because I could make the test really easy and try to get the average of the test come up. But the problem with doing that is that it's really hard. You just sort of have to guess on the test, on the difficulty of the test. And the also is that, I like to make it so that if you're someone who really studies a lot, is that it shows. So especially if you do kind of poorly on the first test, it gives you a lot of room to improve on the second test. So if you get the average grade on the first test and you do really well on the second test, then your overall score is going to go up a lot more than if I just sort of kept everyone within that narrow band, like the university grading scale. Not enough time, other type of factors. Yeah, those things happen, especially during COVID. I think it was tough to kind of, I gave a test one semester where, everyone was in class and there was some poor woman coughed the entire time. And I could see everyone around her was just like this, trying to get the test done as quickly as possible. So those things happen in tests. Idea though is that so that it leaves this question. So what do you do? Do you go through and do you fail everyone, or do you fail most of the class, or do you grade on a curve? So like show me by your thumbs. In your other classes, how often do people basically grade on curves versus just grade based upon the university grading scale? So, yeah. So if people are not, doing if they're using the university grading scale, oftentimes what they do is when they grade, they kind of adjust it then. So especially if it's essay type of questions, is that what you can do is that you can kind of go through and that you can sort of look and think, well, people are doing generally poorly on this question, so I'll just bump up the overall kind of scores on these questions. So you can do that. The other way to do it is the way I'm talking about, where you just basically go through and that you just grade the way it's going to grade, and then you adjust the grades afterwards. And so if you look at within classes, especially in a big class like this, what the distribution of grades look like, sometimes it's a bell curve, so that sometimes there's some people on the high end. Sometimes there's people on the very, very low. Like if this average is 60, you'll get people in the 80s and sometimes the 90s, but you'll get some people down to 10, 15. So it tends to be like this, very, it's not a perfect bell curve, but it looks like that. Oftentimes what you get is you get bimodal, where you get one group that's about, a C plus. You get another group that's like an A minus, somewhere around there. That happens a lot too. But the thing is that, so you got this distribution. So the alternative is that you go through and you basically just grade towards the distribution. That is that, you sort of say, well, let's take the top mark and call it an A plus, take the bottom mark and call it a B or an F. And then you kind of adjust in terms of what, generally how the class is done. So if everyone does pretty well on the midterm, then you might sort of set the average grade at like a B plus. And for an upper division class, you tend to set the grades a bit higher because, you've all kind of made it this far. So you've all shown that you're intelligent people and everything, hardworking and things. On the other hand, if the class, didn't do very well in general, then you might move it down a bit, but that's the general way that it's done. So doing that is that, if I use an alternative grading scale, then you kind of use you'd end up with those type of grades that you would look like. So what I'll do is that if you all ace the test and everyone gets a 97 on it, then you all get A pluses. So I won't mark you down if you hit the university's grading scale. On the other hand, if it turns out that the average is less than that, then what I'll do is I'll feel free to adjust the grades so make it more of a fair distribution of grades. So what it means is basically, what it means is at first is that, I'm just going to count points. So I'm going to give you grades, give you a letter grades or what it might be at the midterm, but for the most part, I'm just going to count at points. It also means is that, if you want to know, like toward the end of the class, if you want to know what your grade is at that point, the best indication of your grade is probably what you got at the midterm at that point. But still, if you do well in the final, then it's going to bump your grade up quite a bit. And the other thing is that ignore any grades that are in CAT courses. So CAT courses, it will automatically give you a grade based upon their grading scale. So what it means is that if you turn in an assignment and you get 10 out of 10 on the assignment, it's going to say you have an A+ for the course, right? That's fair. But also is that after a couple of weeks, I have to put in and do a roll call. How we have to do this thing now where we have to tell whether, we have to give you some assignment within the first couple of weeks so we know who's here. And then we have to report that. Well, what CAT courses did last semester anyways, is it created something called, roll call as an assignment. And then it gave you all, anyone who was here, got an A+. So it looked like when people looked at their grades, it looked like everyone in the class was getting an A+. And so that's only because it just artificially created this thing. So I go through and I try and turn these off, but it doesn't always work. So what it means is that ignore what the grade says in CAT courses. Okay? Any questions about grading? All right. Okay. Anyone here work in healthcare? Do you mind if I ask where you work? I guess I just did. Do you mind telling us where? I'm sorry, say one. Oh, okay. So you worked in the pain management? So these were people who had, was it injuries or was it mostly people who had like chronic pain? Mm-hmm. Yeah. And what'd you do? Yeah, so you worked on that. So when someone come in, like if you've ever been in the hospital, if you're not, usually the first question they ask you when you come into the hospital is, do you have insurance? Right? And if you don't have insurance, then what they do is they instantly sort of say to you, do you qualify for Medi-Cal? Yeah, or Medicare, but usually Medi-Cal. And if you qualify for Medi-Cal, then they'll try and get you Medi-Cal right then. Because, and if you don't have insurance, like if someone came in and didn't have insurance, what would they do? Yeah, so you can pay cash, or they can say, well, we're not going to give you care.
It's like kind of emergency, emergency insurance as well.
You mean, might the people have emergency service insurance?
Like at the hospital, like if you go and you don't have insurance, like you just sit there and like if you qualify, like they give you like just like a window of insurance.
Yeah.
And they just do all they can.
I haven't heard of that. They're giving you a window.
Or they gave me, I didn't have insurance at the moment, so
Yeah.
they gave me like a self insurance.
Was that here in Merced?
That was in the Bay Area.
So they gave you a window of insurance. So you just signed up right there for insurance. Do you remember who it was that you were signing up with? What the company was?
No.
Huh.
I think
But
it was over there by like 2
Huh. Okay. I haven't heard that one before. Sometimes what they do is that they'll like if you're if you come here into Mercy Hospital and that you are indigent, so you're living on the streets, is that well, first off, that hospitals have to treat you. So if you show up with a broken arm, the hospital has to treat you. They can't turn you away. They don't have to treat you for free, but they have to treat you. That's a law called EMTALA, Emergency Management, something. Anyways, EMTALA is a big deal because it means that if you ever need healthcare, you can just go down to Mercy and Mercy has to see you. Like, Mercy doesn't have to necessarily do what you want, right? So like I could go into Mercy and I could say, I think aliens have invaded my brain and I want you to give me a CAT scan and then give me surgery to remove the aliens from my brain. Right? They can say, no, we're not going to do that. So they don't have to do everything, but they have to treat you. They have to see you and at least give you, some type of care. That's a big deal because it means that, in the past, like as we'll talk about, in the past, what would happen is that if I walked out here and got hit by a bus and I got sent down to Mercy, Mercy might say, oh, sorry, you don't have insurance. You need to go find, a hospital that will accept you. Now, most counties have a hospital like that, right? Most counties have some type, like all counties have some hospital that are supposed to treat people like this. Around here, it's Mercy Hospital because it's the only hospital in the county. So the Merced County pays Mercy Hospital to basically treat people who don't have insurance. That doesn't mean they have to treat everyone who comes in, but it does mean is that they'll get some type of funding. So if you're indigent and you don't have insurance and you get hurt and you go into Mercy, Mercy can treat you, but then what they're going to do is that they're going to sit there and tell the county, okay, we treated this person who qualifies for on all this type of basis, and so therefore, consider that as part of Mercy County's funding at that point. Do they have to give you medications? Well, they have to give you medications if it's going to save your life, but not for other things like that. So that's Mercy. I mean, that's how kind of hospitals work. Anyone else in healthcare? Yeah, mind if I ask what you do? What'd you do? Uh-huh. Mhm. And so was this in a neonatal hospital or a hospital within neonatal? Okay. Mhm. So when I talk about the healthcare system, right, is that this is kind of what we're talking about. So there's, let's see, where's hospitals? Here's hospitals over here, right? Here's doctors, here's community health centers, emergency services. But then notice is that there's all these other things as well, like, there's public health agency, but there's also drug treatment, law enforcement. Do law enforcement deal with healthcare? Yeah, law enforcement deals a lot with healthcare. In fact, anyone with if there's someone who's having a mental health crisis, is that, typically it's law enforcement goes out there. I mean, this is why, after the George Floyd got killed, is that there was started to be all this push to basically make it so police don't do that anymore. So it's not the police, because police aren't trained as mental health counselors. And so, if the police goes out there and someone's having a mental health incident, is that they oftentimes don't need, people with guns pointed at them. So instead, what some cities have done and are doing is going through and switching it over so that it's not police who go out for a mental health type of call like that, but instead it's social workers, and it's people who are trained to actually deal with. And they found is that the number of incidents goes way down when you have, when you don't send police out there. And it's nothing against the police. It's just that that's not what they're trained to do, right? So yeah, but police have a lot to do on tribal health. Like up in Mariposa, there's a tribal health center. Over in Oakhurst, there's tribal health center. So if you go over to Bishop has the Shoshone tribe, I think it is over there, that there's a health center there. And so, reservations are basically sovereign states. And we'll talk about the Indian Healthcare Service, but they're sovereign states. And so, they do have their own kind of healthcare centers, usually. Fire, transplant, etc. So one thing to notice about this is it's called the public health system. And it's kind of misleading because, this term public health then is being used in a number of different ways. So like what I talk about public health agencies. So the public health department at UC Merced in Merced County is the public health agency for the county, right? But that's just here. When we talk about the public health system, we mean everything. So hospitals, all these things that have nothing to do with what we think of as public health. So it's just more generally the healthcare system. So I'm going to point this out because this is going to be a point of confusion as we go through, that sometimes we'll talk about the public health system. And you might think to yourself, oh, that's what the public health department does. And it's like, no, that's not what the public health department does. Public health department does some specific thing within the bigger healthcare system. Okay, so let's say I walk out here and I get hit by a bus. So what happens to me? So I'm laying there, broken leg. What happens? Call an ambulance. So hopefully someone calls an ambulance for me. Ambulance comes out. What does it do? Yeah, they take me over to Mercy Hospital. So Mercy Hospital, then where do I go when I get to Mercy Hospital? The ER, so the emergency room. So here in California, all emergency rooms have to be connected. Emergency departments have to be connected to a hospital. So you can't have emergency department that's not connected to the hospital. There are some places like critical care units, which are sort of halfway between the doctor's office and the emergency room. But for the most part, for things like that, you go to the emergency room. They treat me there, put a cat or probably X-ray me, put a cast on me, maybe give me some pain medications, and then send me home. I mean, unless it's really bad. If it's really bad, then what they do is they'll admit me to the hospital. So you have your emergency department and you have the hospital. So if you go in the emergency department, you're not technically admitted to the hospital yet. But if they decide that, for some reason you need to stay, then they can move you just down the hallway, but now you're technically in the hospital. And that's important because when it comes to insurance, is that the insurance pays different amounts for emergency care versus hospital care. So, okay, so let's say they treat me in emergency and then they go through and they release me and I go home, and that after a week, I come back and they check to make sure that it looks like it's going okay. And after 3 weeks, they come back and they, look at it again, and then they cut off the cast, and maybe I have a limp, and I walk for a while in a walking boot, and then I either get better or I don't get better. That's kind of the, what would happen for this. That whole thing is called episodic care. Right? And the episodic care starts when you need care, and it ends when the healthcare system has kind of done what they could do for you. So that episodic care could end with me, being able to have a fully functioning leg again. It could end with me having a limp. It could end with me dying, whatever it is. But that's when the episodic care is basically from when something starts to it, when it ends, when the healthcare system has sort of done whatever they can do for you for that type of thing. This is the basis of what's called clinical guidelines. So have you ever heard of clinical guidelines? Big deal in healthcare, clinical guidelines. We'll talk about that. Essentially, what clinical guidelines do is they lay out the pathway of care that people should get. Okay, so what do we want? Well, notice is that first thing that I would like to have after I break my leg, first thing I would like to have is I would like to have access to healthcare. So that means that having an ambulance that comes in a timely manner, that takes me to a hospital, that the hospital, can see me, etc. So the first thing I need to have access to care in the US is basically insurance. So for a broken leg, they would take me would the ambulance take me over there? Yes, the ambulance would take me over there because they have to. Would Mercy see me? Yes, they would see me because they have to. Would Mercy try to charge me for it? Yes, Mercy would try to charge me for it. If I didn't have insurance, then they'll try and charge me for it. Can they foreclose my house if I don't pay? Yes, they can go through that. Basically they're charging you $10,000, and then if you can't pay the $10,000, then they'll get bill collectors to go after you. So that's the first thing you need to have access to healthcare is you need to either have an EMTALA that tells you they have to pay, or you have to have insurance. If you get sick and that you're not dying, but you need to go to a doctor, just then if you don't have insurance, will the doctor see you? Maybe, maybe not. I'm not sure if you've ever been on Medi-Cal, but people on Medi-Cal oftentimes have trouble getting a doctor. So like when I first moved here, and I had to find a doctor in Merced, and so I called up, and the first question they'd say is, "What kind of to call up to see if I could see this doctor?" First question they ask is, "Do you have insurance?" Right? It's always the first question. Second question, if I said yes, so I said yes, I have Anthem Blue Cross. Second question is, yeah, well, they say, is it Medi-Cal or is it other private insurance? And I'd said, oh, well, it's through the University of California. And then they'd say, okay, well, we're having an opening in 3 weeks, right? But one time I decided to say it was Medi-Cal, just to see what the difference was. And they said, oh, sorry, we're not taking Medi-Cal patients anymore. And so you have to just keep calling. So means that if you've got Medi-Cal, you have the right to have a doctor. It doesn't mean that a doctor has to see you. So people on Medi-Cal often struggle to find a regular doctor. Why don't doctors want to see patients on Medi-Cal? Yeah.
The doctors have a schedule for the team for the place
Uh-huh. Well, I mean, most doctors can take Medi-Cal patients.
Yeah, it's not really good doctors.
Well, true. That's a separate issue. So like, why, but like, so, the doctor can take a Medi-Cal patient. You probably took Medi-Cal patients at the hospital, right? Did you do billing at all? Uh-huh. Yeah, so typically Medi-Cal pays about 40% of what private insurance pays. So the reason why doctors don't necessarily want to take Medi-Cal patients is because they get paid 40%. So I mean, what doctors would like to do is they would like to have private insurance patients like me, because then so they'll take some Medi-Cal patients, but they're not gonna, if they took all Medi-Cal patients, they'd be earning 40% of what their colleague kind of earns. And so that's really the reason why they don't do it. Same thing with hospitals. Like I live in Mariposa, and Mariposa Hospital is, it's going through all these problems, and they closed down and everything else. I was talking to the guy who's the director of the hospital up there, and he said that he used to run Mammoth Hospital, just right across the mountains. Mammoth Hospital, or Mammoth is kind of similar size to Mariposa in terms of the population that lives there. And he says that Mammoth Hospital is flush. And in fact, I had to take my son there last year, and that it's a nice hospital. Mariposa Hospital, ooh, if I cut something off, if I cut off my finger, I may go to Mariposa Hospital, but anything else, put me in a car and drive me to someplace else. So it's not something where I would want to get long-term care. And the difference between Mariposa, I said, well, why the difference? And he said, there's one difference. Who gets injured and has to go to the hospital in Mammoth? Skiers. Who has money? Skiers, right? Mariposa, not a lot of people with money in Mariposa. And so that thing alone, the fact that Mariposa has, had 60% of the people were on Medi-Cal or Medicare, and Mammoth Hospital, 80% were private insurance, that tells you why that hospital is very flush, and Mariposa Hospital is struggling. So it's the same thing with doctors. Doctors in this region, this is a medically underserved area, not enough doctors. Why don't we have enough doctors? It's not because of insurance anymore. It's because this area has 50% of the people are on Medi-Cal. Whereas like if you look in the Bay Area, if you're in Marin County, you're looking at probably 20% on Medi-Cal. So it means that people who live in the Bay Area, who treat in the Bay Area, are going to just have a higher number of private paying patients than doctors here. Also want good quality care. One of the things that, I hate to say this, but some of the doctors I've talked to in this region say that, oftentimes there are lots of good doctors in this region, and there's lots of not really good doctors in this region. And they kind of make the point that, remember that half the doctors are worse than average. And that sadly, a lot of the doctors the best doctors tend to go where they can kind of make the most money. But also is that, if you're in an area like here, a medically underserved area where where it's tough to, you've got too many patients, and that you're always being, your schedule's always being worked hard, is that it's easier to make mistakes. So there's also the problem in these areas that the quality of care just tends to be lower than it does in other regions as well. You also want good, efficient, seamless care. That is that one, and we'll talk about this, but one of the things that, I want, when I break my leg, I want to have the ambulance, works well with Mercy Hospital. I want to have when I'm discharged, when I'm in Mercy Hospital, that I can get a screening, get a scan of my leg pretty easily. I want to then, when I go home, to have my GP, to have my family doctor know what happened in Mercy Hospital. So there's all these different, there's all these different players here, and that you all want them to work together and like know what each other's doing. The problem has always been in our healthcare system is that it's very siloed. So if you think about like here, who's the major provider of family care here? General practitioner here. What clinic is the big one here? Yeah. Well, they're a healthcare group. So what they are is that they're basically a grouping of different type of doctors. But the big clinic is Golden Valley, right? Because Golden Valley is an FQHC, a federally qualified health center. Golden Valley is supposed to, they're a federally qualified health center, meaning is that they get some extra money from the federal government to basically treat people at low income. So they should be, in theory, the place where if you don't have insurance, you could go to Golden Valley and they may not treat you for free, but they're supposed to treat you on a sliding scale and things like that. So but Golden Valley is not the same thing as Mercy. And so the question is, well, how does Golden Valley talk to Mercy? Right? How do people who go to Mercy Hospital for Golden Valley patients, how do they know what each other's does? Well, you'd like to think that there's some type of communication system that goes on between the two. And it turns out that this is a major problem in the US healthcare system, is that there's not all these different type of organizations have their own kind of information systems, and they don't necessarily want to share information. Like the public health department here has been working for 10 years to get an information system so that Golden Valley and Mercy Hospital can communicate with each other in terms of what the patients are doing. Why doesn't Golden Valley just sort of say, well, look at Mercy, we'll give you access to our records, and Mercy says Golden Valley will give you access to our records? Why don't they want to do that? So one is HIPAA, right? So the HIPAA is the thing that makes it so that that our health information is protected. But also is that organizations don't typically like others looking at what they're doing. Partly because they're afraid for competition reasons. Is that if I see that if I get if Mercy got my name and saw that I was employed by the university with really good insurance, that maybe Mercy would sell that information to somebody who would then contact me and say, why are you going to Golden Valley? Why don't you come to our healthcare center instead? So there's that kind of worry. But then there's also worry just that what if Mercy looks and sees that this person got that drug and they had this type of adverse reaction? And so, from legal standpoints too, is that they're afraid of it. Yeah. Yeah, so what they're afraid of is that like someone at Mercy is going to look and say, hey, Golden Valley, you got treated with this drug here, and they were doing this. They clearly made a mistake. You should sue them. So, from Golden Valley's standpoint, they don't want these other kind of healthcare providers to sit there and that. So it means that all these healthcare providers are a little bit wary about sharing information. I should also mention at this point. So this is a theme that will come out whenever you talk about healthcare. Whenever you talk about healthcare, there is what's called the sacred and the profane reason for doing things. The sacred reason means that it's the thing that, they're doing it for the benefit of the patients and things like that. The profane means they're doing it for their own self-interest. And so again and again in healthcare, when we talk about these issues, there's going to be a sacred and a profane way of looking at it. So for example, in this case with the information, the sacred reason why Golden Valley would say that they don't want to share their information is they say, we're protecting our patients. right? We're protecting our patients against someone stealing their information and doing harmful things with it. Is it true? Yep, it's true. There's a profane reason, which says that we also don't want to be shown that we're liable for doing anything. We don't want someone to steal our patients, etc. Right? So that's the profane kind of self-interested reason. And both of these things can be true. So when we talk about healthcare, especially when we start talking about doctors and doctors' motivations, is that we're going to end up in this sacred and profane discussion a lot. In that, you can look at it from a sacred standpoint and say, no, doctors are doing things that are best for people. They're not doing things that are self-interested. And from the profane reason, you can say, but everything they're doing is in their self-interest. So, but there's more that we want from our healthcare system as well, right? We want to make sure that, we want to emphasize prevention. So we don't want sort of a healthcare system whereby people just sort of come in and get treated and leave and then go and get sick again and come back in. We want to kind of have the more, the upstream public health kind of do the right thing in terms of dealing with the social conditions and such. So we also want that. We want to be able to have a good system for monitoring for future health. We want to have programs for people who have special needs. So we want to make sure that it's not just like a one-size-fits-all for everyone. We want to have coordination of care for natural disasters. So there's a lot of things then that means that, that we want our healthcare system to basically to be efficient in terms of how people can access it, how good the quality of care is. We also want to be low cost, so we don't want to cost too much. And we also want it to be very, very responsive to what different people, sorry, there's a fly that's buzzing around me, but the needs of different people. Okay, so let's see. So how are we doing as a healthcare system? So we'll go through 4 different things. We'll go through how we're doing in health outcomes, how we're doing in access, how we do on quality of care, and how we do on cost of care. And we're going to compare ourselves to the rest of the world. And we do that a lot in healthcare, is that we do compare ourselves to the rest of the world. Oftentimes what we do is we compare ourselves primarily to what's called the OECD countries, the Organization of Economic Cooperation and Development. OECD countries is kind of the European countries and Japan and some of the other countries that are sort of have similar type of income levels as we do and similar levels of development. So we're not comparing ourselves to Angola or to Iran or some other places that have a different type of social conditions and different type of healthcare systems. Okay, well, I should just ask you. So first one we'll do is we'll do life expectancy. So how do you think we're doing compared to the rest of the world in terms of life expectancy? Are we better? Are we about the same? Or are we worse? So yeah, somewhere on the same. About the same. Yeah, you better? Good on you. That's good. Keep that level of enthusiasm. No, we're pretty bad. So we are, in fact, you notice is that, that this life expectancy has actually been going down over time. In fact, over the last couple of years, it's gone, even before COVID, it was going down. Why is our life expectancy going down in the US? Why has life expectancy gone down in the last 5 years? And before COVID, had nothing to do with COVID. The opioid crisis, right? So the opioid crisis, especially in the Midwest, where people were dying and they were dying at age 30 and 35. So actually our life expectancy has been going down. Yeah. Say it again. Well, okay, hold on to that. We'll get to, is it too expensive? Okay, next one, suicides. How are we doing in suicides? Are we better than the rest of the world? Are we about the same? Or are we worse? Yeah, worse. Worse than the rest of the world. Are there more suicides in rural areas or urban areas? Well, there's more attempts in urban areas. There's more successes in rural areas. So kids in rural areas are more likely, especially for teen suicides. Kids in rural areas are more likely to less likely to attempt suicide, but more likely to be successful. Why would that be? Yeah.
mental health and also to like get them to a hospital.
Yeah, but there is, that's all definitely true. But why are they more, when they do decide to commit suicide, why are they more successful? More guns, right? It's basically comes down to availability of guns. Is that if you're in a place where, where there's guns around that, and you use guns to try to commit suicide, you're much more likely to be successful than if you use pills or if you use something else. Okay, so suicides, nope. Let's try adults with multiple chronic conditions. We're number one. So 28% of people have multiple chronic conditions. What percent of people adults have a chronic condition? I think it's about 60% have a chronic condition. Obesity rates, again, we're number one. Then for healthcare utilization, so do we, how, in terms of how does it look in terms of us with doctors? So this is where you break it down by physicians, so primary care. There's secondary care, which is hospital. And then there's tertiary care, which are cancer centers, et cetera. What you'd like to see is you'd like to see more primary care visits. You'd like to see less hospitalizations for conditions that don't need it. And you'd like to see longer hospital stays. That's what you'd like to see, right? So this is the supply of doctors. So, here's the US down here in terms of the average physician visits per capita. So it means that we actually go to the doctor less than other places. This is immunizations. So we're pretty good on immunizations and on breast cancer screenings. Pretty good on that. That's because we have programs that kind of, specifically try and target it. Here's hypertension and diabetes and hospitalizations for hypertension and diabetes. So we're kind of up near the top of that. Not as big as Germany, though. So I was thinking, why Germany? I think it's alcohol. I think so. Acute length of stay. Here's the US, so we're not that high in the average length of stay. They tend to get people out pretty fast. Quality of care. So the conclusion of that is that, well, we're not necessarily leading the world in terms of going through and seeing doctor's visits, longer hospital stays, all the rest of it. Not seeing that. Quality of care. So a couple different types of ways that you can look at quality of care. So one is what's called adverse events, or they call them medical misadventures, which is a great name for errors in the hospital. So this one is survival rates for breast cancer. And that what you see is that the US is pretty good, right? In terms of survival rates. Here's survival rates for cervical cancer, not quite as good. What's the difference between the two? Well, this one, breast cancer has better screening programs than cervical cancer. So therefore, that's why that's what's related to this survival rate. It's not the treatment per se. Like, from what I've seen about, especially these different countries, there's not really that much difference in the kind of healthcare that people who have good healthcare get. Right? So it's not like people in other countries, they just don't have as good of doctors. In fact, I spend a lot of time going down back and forth to Bogota, Colombia. And, I would go down there and deal with the people in the medical school down there. And so I got to see what the healthcare is like in Bogota. And what I came away thinking is that, well, if you've got money in Bogota, then you get pretty much the same healthcare as you get in Stanford, like in Palo Alto. And if you don't have money in Bogota, then you get horrible care. And so, and then if you look at our region, you think, well, if you live in Palo Alto, you're going to get pretty good healthcare. If you live in Merced, you're going to get pretty poor healthcare. So in terms of looking at how to think about differences in quality of healthcare, it's partly income, right? It's partly income, but it's also rural versus urban. Is that rural centers tend to have much better healthcare than rural centers. Here's adverse events. And so the US is, adverse events, again, is sort of, problems in the hospital, and this is disability adjusted life years. So this is basically consequences from it. So we're not necessarily leading the world in terms of quality of care. And then this is mortality based upon things that essentially you could kind of do something about. And again, we're kind of leading the world. Efficiency. So what we'd like to see is we'd like to see, minimize unnecessary care and have low cost of care. So remember is that, the cost of care in the US is for anywhere. The cost of care is the volume times the price. So the volume means how much stuff you get, and the price means what you're charged for. So you can have high expenditures either because you use too many procedures or because you have too high of a price. So how do you think we do? Are we higher than the rest of the world in terms of our expenditures? Are we about the same? Or are we lower? We are much higher, right? So this is, well, first off, this is hip replacements. So this just shows the average number of procedures. So we got more procedures, but not that much more. MRI exams don't have necessarily a lot more of MRI exams, right? But here's healthcare spending. Healthcare spending means that we're like, this is what, after 2015, we're about 18% of GDP. So that means like 1 out of every $5 is spent on healthcare. So if you want to know why it is that there's so many jobs in healthcare, it's because 1 out of every $5 in the economy is basically spent on healthcare. So, and we're much higher than everyone else. We're about double. So the average OECD rate is 8.8% of GDP, and we're at like 18% of GDP. So we're about double. So we don't necessarily use that many more procedures. We're not in the hospital more. We don't go to the doctor more. Then why is it that we have such high costs? Well, what's left? If it's not volume, it's what people are paid. It's price, right? So it means that prices are just a lot higher here. It means that doctors make a lot more, that owners of hospitals make a lot more, stockholders make a lot more, everyone makes a lot more out of money out of healthcare without necessarily increasing the volume. Here's per capita spending. So this is again the US, so about $10,000 per person. And you have to remember that we've got maybe 10% of people who have no insurance. So, and we have another 30% who are on Medi-Cal, so they're not using very much in healthcare. So, even given that, we're still up at $10,000. Then there's COVID. How do you think we did COVID-wise? Give me we did good COVID-wise, we did okay COVID-wise, we did poor COVID-wise. So why do you think we did poor? For those of you who say we did poor, why do you think we did poor? Yeah. So a lot of people, great point. A lot of people thought it was made a political issue rather than a health issue. And so what kind of impacts did that have? Yeah. So that it was partly there was a lack of trust, and it caused a lack of trust in the medical system. Yeah. Right. Yeah. So the hospital capacity itself was just not ready to, wasn't able to handle the capacity. So okay, what do I think? Well, I think that my sense is that the initial response was really poor, right? Because there were lots of training in terms of how to go through and deal with the pandemic as it went through. Like every year public health departments would have training in terms of how to deal with the pandemic. So it wasn't like it was new, But what was supposed to happen is that as soon as a pandemic hit like this, is that the CDC was supposed to meet planes as they came from these infected areas and get the names of everyone who was caught the plane and where they were going to. And then what they were supposed to do was they were supposed to give those names to the public health departments, and the public health departments were supposed to then contact the people and say, hey, look, you were exposed, and so we want you just to, isolate for 14 days, whatever it is. And then they would call them back and they would, find out, are you sick? Do you have any symptoms, et cetera. And then if they were sick, then they would isolate them. That was kind of the way the system was supposed to work. And that those people who were out there in the public health departments they were the contact tracers. So that the contact tracers were the people who were supposed to call up and say, we know you just came from infected area. So early on, there was a problem in that the CDC wasn't meeting the planes. So it meant that public health departments had no idea who was in their region, who was getting sick. So as a result, places like Madeira, they were having a massive outbreak, and they just had no idea who it was that was sick. And so all they could do is just monitor the speed at which it was increasing, not necessarily trying to control it. Other places like Santa Barbara, they were able to control a lot more because they had more contact tracers, and that just hit there later. But still, at some point it hit them. But so from the healthcare standpoint, it's like, well, that seemed like it was the local public health departments did okay. The CDC, did remarkably badly in terms of it all. In terms of the hospitals, we didn't really have the problems like New York had and Italy had in terms of the hospitals being overrun. And at the hospitals here, they seem like they work pretty well with the public health departments in terms of kind of making it so that they were ready for the capacity. So there definitely were, like in the early days, not enough ventilators and such. But after that, the hospitals didn't seem like it was an issue. What did seem an issue is that once it got politicized, like you said, is that then people stopped telling the contact tracers, what they were doing. And so like a former student of mine works up in Mariposa at the public health department up there, and he was a contact tracer. So he had to call people up. And he said that, he'd call someone up and he'd say, well, you've been identified, you just got tested positive because they had a positive test. Have you seen anyone, been around anyone? And the person would say, no, I haven't seen anyone. And then 20 minutes later, they'd call someone else who's also infected, and the person would say, oh yeah, I was with this guy. And so they were just lying to him at that point. And for the reasons that you're saying, is that there was this suddenly became this lack of trust in government. And the people who worked in public health departments got, they started to get death threats, started to get really abused by people. So that definitely turned ugly as went through. In terms of what we can learn from it going forward, well, we'll talk about that. But I think that is the, that is that COVID was sort of COVID was the thing that it didn't cause all the problems in the healthcare system, but what it did is that we always knew that these problems were there, and it just highlighted all these different type of issues going forward. Okay, we're out of time, so we'll start there next time.